It gives me great pleasure to introduce Dr. William Jeffcoate, whom we all know, but it's my pleasant duty to introduce him once again to all of you. He was appointed as a consultant endocrinologist in Nottingham in 1979, and he formed a diabetes specialist diabetic foot clinic there in 1982. He resigned from his full-time post in 1997 in order to devote more time to research. He was a contributing editor at the Lancet from 1997 to 2007. And together with Professor Francis Game, he established a specialist diabetic foot, or rather foot clinic, foot ulcer trial unit in 2002. His current main interests are the causes of Charcot foot, which is a very important problem, and the importance of audit in routine clinical care. He has been the clinical lead of the National Diabetes Foot Care Audit of England and Wales from 2010, and he has to his credit over 200 academic papers. And the first of these was in the Journal of Endocrinology in 1970 about dihydrotestosterone. So on to you, William, for the first talk, which is on the classification of wounds.
So I am going to talk about classification, and you might think that that's a pretty boring thing to talk about. Nevertheless, I think it is important because when I'm talking about classification, it's essentially a way of describing foot ulcers, because linked to that is audit. Because if you can describe ulcers, then you can count them and you can put them into groups and you can work out how each group differs, how long it takes to get better, whether they have an amputation, etc. And you can then start to compare your practice with other people. So although this seems a bit of a tedious subject, classification, I don't think I would have logged on to a talk about it, but I had no choice. The implications are very, very important. So the slide that you see in front of you, if you have a question of how do you look at classifications, well, the good thing is that it's all been done for you already, because the International Working Group of Diabetic Foot has, as you know, every 4 years, a series of working parties who try and work out the evidence for this or that. And there was one which reported in 2019, and you can see the participants in that. But you can also, if you see the L at the bottom there, it says IWGDFguidelines.org. Anything about classification, you can actually stop listening to me now and you can go onto those guidelines, and you've got plenty of time to look at it. But let me try and summarize the details. Can I have the next slide, please? And so why should we classify foot ulcers? Now, you might get an ulcer which looks like that, and if you're experienced in the field, you would describe this one perhaps as being, well, it looks as if it might be a bit infected. There's a bit of redness there. Whereas this one here looks like a straightforward neuropathic foot ulcer. It doesn't look infected. But then you would see these two over on the right here. You might think, well, obviously the bottom one, they've had a pressure sore on their heel, and that looks as though it's infected with it spreading infection, soft tissue, and either that one or that one might have osteomyelitis. So I'm describing these to you as you could describe them to anybody else. But what we're doing is selecting features, clinical features of what is different about this foot ulcer from that foot ulcer. Because if we're going to start comparing how is that one doing, how quickly does that one take to get better, etc., then you've got to be able to say what sort of ulcer is it that you're talking about. And so we need to have a classification to try and decide how you would describe the ulcer. Have the next slide. But when you've got a classification, I'll come on to that in a second, there are lots of things you can do with data. It could just be communication between professionals. That's what we're talking about. You might think that you could predict clinical outcome. You say, oh, it's one of those now, that won't get better for 4 months, or there's no way that this person will get away without an amputation. Or it could be to guide management in some way. Signs of infection, obviously linked to treatment with infection. Or it might be linked to decision making, and obviously the main contender here is revascularization. If you've got access to it, and how would you decide whether you should go and consider it? But my main interest is the last two really, is comparison between centers, and eventually comparing between centers in the same country or regions of the country or different countries. And so that's what is the background. That's the real value in my mind, why we should be classifying. Have the next slide. And how do you classify then? If you're going to classify foot ulcers, what sort of things can you divide them up in? Well, you either go for very precise details with doing tests, and it takes time, and that might be appropriate. You might be interested in one particular form of revascularization, perhaps, and in which case it is very important to try and describe what ulcer you're talking about. But in other cases where you're more interested in foot ulcers as a whole, you're interested in much more simple categories, current criteria. So you collect less data, it's less equivocal, you don't need special tests, and it's much more quick. And so you have to decide why you're classifying. Next slide. And whichever system it is, you're collecting data on a number of different factors. Person data, ethnicity, sex, age, accessibility to hospitals, it might be, limb data, PAD, neuropathy, deformity, or the ulcer itself. So classifications tend to have combinations of these different categories. Next slide. Now that's deliberately boring. That slide comes off the IWGDF website, and this summarizes the working group findings of 37 classifications, which they identified in and published in 2019. Next slide. And as I say, what the group did that was examining all these classifications, they had to validate them. They had to say, well, is that a good one? Is that a bad one? How reliable is it? And what they did was a systematic review on all the different classifications that they were there, which is a lot of work because you've got to read all the papers. And they were looking in particular for validation that the classification worked for whatever purpose it was being used. One of the other important things was to make sure it's about people with diabetes. And so there was a rule that 80% of the papers that would be considered, that the papers being considered had to have a population of which 80% had diabetes, to make sure that it was relevant to the diabetes world, because that's what our interest is. And then all the papers were also assessed for quality in terms of bias, etc., and reproducibility and all the other standard things. Next slide. And of all those 37, they've got their good points, they've got their bad points, but I will list 4. And those are names which will probably be familiar to all of you one way or another. And the first one, the Meggitt-Wagner classification, has been around for a long time. In fact, I think it's been around for too long. And I know there are people who are still using the Meggitt-Wagner classification, but it has the problem that it's too imprecise. It's got 2 categories out of 5 on gangrene, and it just doesn't cover all the different things that should be considered. And so, next slide. I'm taking that one off the list. Ooh, we just took off another one off the list. We can't go back, please. Go back again. Thank you. Because with John Steinberg here, I can't ignore the University of Texas. He is here. So we'll get extra exposure to the University of Texas, which is where he was before, where he is now. And the University of Texas classification was launched in the late 1980s. and indeed really held sway for a long time, for 20 years plus, as being perhaps the best classification, most widely used that was available. But it has been superseded in the last 4 or 5 years, perhaps by Wi-Fi, and I'll come on to Wi-Fi in a second because that incorporates many of the University of Texas details. Next slide. And so now, if we're classifying, the only ones that I'm interested in any detail, others will feel differently, but these are the ones that I'm interested in. One is SINBAD, which includes 6 components and is very simple. And it uses clinically obvious signs. And that contrasts a little bit with Wi-Fi. And by the way, when people spell Wi-Fi, they're never sure whether they have a big I and a little f or a big I. But just for the record, just remember that doctors are all big-headed. They go I. So it's 2 big I's and 1 small f. I'll move on to the next one quickly. And next slide, please. The SINBAD system has just got 6 components and they're all yes, no. And they're very, very simple. Is it forefoot? Is it hindfoot? Does the person have signs of peripheral artery disease? Yes, no. Neuropathy? Yes, no. Very, very simple things. And actually, you can do it in 2 minutes in the course of a routine clinic. And that has a lot of benefit if you're trying to collect data on an awful lot of people, like every person that you see. And so that's where perhaps a very simple classification like this has its value. Next slide. Wi-Fi is different, and this has got a big F at the bottom left there instead of a small f as it should have. And this is built on it's very similar in some ways to the University of Texas, which I described, and it's much more complicated. And I'm not going to go through the details of it, you can look it up. But the key component, in addition to its 2-dimensional way of looking at depth and area, etc., infection, it also has in the bottom there much more precise data on assessment of peripheral artery disease, which involves time and it involves equipment and is not accessible to everybody. So for people with a particular interest working in specialist centers, Wi-Fi probably is very valuable for the purpose that it's being used, but it isn't necessarily appropriate for everybody. Next slide. Now, what the International Working Group did was to assess all these in this systematic review. I'm very interested in SINBAD. In fact, we described it. But so anything about SINBAD didn't involve me at all. And similarly, anything else concerned with the Wi-Fi didn't involve Joe at all either, who was also on the committee. Nevertheless, the committee, the independent committee, because obviously trying to avoid bias, decided that the reason for recommending SINBAD for communication between healthcare professionals, the recommendation was strong and the evidence was moderate. Next slide. And then just in detail, it's because it was simple and quick, it didn't need specialist equipment, it covered most of the components, and that's why it came out with a strong support. Next slide. There was another question in the working group that they looked for, and that is, can you use a classification, any of the 37, to try and estimate prognosis? And the conclusion was, there's no evidence that you can do that. It's not valid, none of them have been validated for it. Next slide. And there are 2 other components. I'm just showing you the detailed results. The top box was, can you select any classification for describing infection? Well, there is an international working group definition for infection. And so they said, well, yes, you can use the international working group definition, but actually the evidence is pretty weak. And then the 4th one was about peripheral artery disease. And again, there is evidence, a lot of evidence for the use of Wi-Fi. And using it to try and decide whether someone would benefit from revascularization. But the problem in 2019 was that very few of the studies had been done on people with diabetes. Or if they were done, they were mixed population of diabetes and non-diabetes together. And so it was actually only given relatively weak support because of the fact that it hadn't proved for a diabetic population, which is what the IWGDF is interested in, that it was actually specific for their purpose. I think that'll change. It's obviously all this work is being done again and will be updated and republished in 2023. And so I think that that will change and Wi-Fi will come out with much stronger scoring. Next slide. And there was one more thing about Sinbad, and that was audit. And this is my main interest. And this is where I'm going to finish in 3 or 4 slides. So the group recommended that if you were undertaking audit, if you were measuring how well you do, how many amputations you have, how many people survive 6 months, whatever it is you're choosing to compare with other people, then Sinbad at the moment is a very reasonable one to use because it's so simple and quick. And when these data were assessed, as you can see at the bottom, the data were based for Sinbad use in a system which we have in England and Wales, which is assessing outcome, comparing outcome between all participating centres, specialist centres in England and Wales. And at that time, in 2019, we had 20,000 foot ulcer episodes. The answer now is that that same audit of outcome has got 120,000 foot ulcer episodes, and we got some more data, etc. Next slide, please. So I was asked at the beginning, why classify foot ulcers? There's all sorts of reasons, and you must choose what classification you want. And if you want to look at the list, then just look at the IWGDF online. It's very easy and very easy to read and obviously accessible. But coming back to this question about undertaking audit, can I have the next slide? It's not audit, the word audit in the USA tends to mean money. In what it's being used for here is not to do with money, it's not to do with budgets, it's all just about measuring things, and in particular, measuring outcome. And you're wanting to do this to determine how good is your routine clinical practice when it's compared with other people. So whatever you count doesn't matter, it's up to you and the people that you're working with. It could be all the units in your country, or it could be a smaller group. You might just want to know, how many people do I see? How many people come to our service? You might want to know how many people who come to our service have got bad ulcers. Defined how you like. If you can define them by the Sinbad system fairly easily, but there are others, however you want to do it. And then you need to have some outcome measures. Traditionally, people use death and major amputation because those data are already collected routinely by hospital groups. But actually, the percentage of people who die or have a major amputation is really quite low. And that makes them insensitive measures for comparing the effectiveness of what your work is. And healing is a much more valid measure if that is what your interest is. And healing by 3 months is a very good way of determining effectiveness of what you're doing. Next slide. So if you want to know about the actual audit that we run in England and Wales, just Google NDFA or foot care audit, as it says here, you'll get in. And the data that are published are up to 2019. And as I said, on 20,000 episodes, foot ulcer episodes in England and Wales. The actual follow-up data are now available, and we have 120,000 foot ulcer episodes in the 2 countries, and we can compare places. I can't show you the latest data, they're embargoed. Next slide. But what I can tell you is the basic findings are the same, and that what we know is that if there is more than 13 days between someone going to see a doctor or a nurse or someone somewhere and saying, look at my foot. If there's more than 13 days before they see a specialist, the ulcers are much more likely to be graded severe. And both that time lag and the presence of a severe ulcer as opposed to a not severe ulcer, they're both statistically linked to the time to healing. And the other good news I can tell you is that over the years that this audit has been running, since 2014, we've been able to document in our country a steady improvement in the numbers who are healing by 12 weeks. And that's fantastic. It means that by working with specialists all over the two countries, we're actually getting people to change their practice and making it good quality care accessible to more people. Next slide. And so, if I have next slide, this is my final slide. Classification, I think, is an essential component of audit. And the reason for that is, if you might think you're a very good doctor or nurse, podiatrist, whatever, but if you don't measure what you do, you won't ever know how good you are. And if you won't know how good you are in comparison with other people. And so the whole point, I think, of the future is that we should be classifying however you like, and we should be measuring everything that we do, and then comparing it with other people so that we can see how well we're doing, not so that we're punished or fined or anything like that, but so that we make clinical practice better. Thank you.
Thank you, William, for this wonderful presentation.